Okay. So this is the case. We are going to perform a TAVI case, but with some particular issues that we should focus on. Next. This is an 86-year-old male who presented with dyspnea and hair failure, a long history of hair failure. He was treated in another hospital. He has history of hypertension, smoker. He also had a very long history of a right pleural effusion, which was treated with thoracentesis and then with the pleurodesis. And also coronary artery disease, which was treated there with the right coronary artery PCI in another center. Next. So the ECG is quite normal, 63 sinus rhythm. Blood test is also normal. The echocardiography or echodoppler evaluation showed a severe aortic stenosis with an area of 0.6, a gradient of 64 and 36. Afterwards, Dr. Mukasel will tell you how is the evaluation before starting the procedure today. He also has a tricuspid calcified valve with the left ventricular ejection fraction of 55. He has mild frailty, but he is not futile for this treatment. Next. Unfortunately, we don't have the coronary angiography. The right coronary artery is dominant with severe middle segment stenosis, which was treated in another, which was unsuccessful in another center and then was translated to here. Next. So this is the right coronary artery with this very tight stenosis in the middle segment, calcify in the ostium. Probably this low and anterior takeoff of the coronary was difficult for the other people doing the PCI. Here you can see we are using the Naplatz guiding to have a good support, regular wire, pre-dilatation. Next. And then we deploy a long DES. Next. This is the 3.0 by 30 millimeters in length. DES is a Firehawk stent. Next. And this is the CT scan evaluation. He had a 23 by 26 in diameter annulus. The perimeter is 78. With an area of 480, coronary height is 16 or close to 17 on the right, and on the left ostium is at 11. Aortic angulation not too much, it's 33. The LVOT measurements are quite similar to the annulus, a little bit smaller. Next. So this is the annulus and also the sinus of Valsalva, which are 29 and 32 and 30. And this is the measurement of the annulus, which were already mentioned. Next. This is the LVOT, quite similar to the annulus, and the sinotubular junction with some calcification on the area of the right cuspid about the right coronary artery, which was shown during the coronary angiography. It's not that big, 23, 24, and 23, again. Measurements for the sinotubular junction with some protruding calcium there. So it's important for pre-dilatation. We are going to pre-dilate, but with not too big balloon, just to try not to touch too much this area. Next. This is the ascending aorta, 20, I would say in average 30 millimeters in diameter. This is the calcification of the leaflets, especially the left coronary cusp is heavily calcified on the border, so we are going to pre-dilate with a 20 millimeter balloon. Next. This is coronary height, I already mentioned, for the left and the right, which are okay, no problems with the, or I guess, no problem with this. Next. This is the angulation, 40 for the aorta with the annulus. Next. On the next slide, please. And this is the right and left cusp overlap position for working. It's going to be on the right, 16, and caudal angulation of 18. So it's unacceptable and comfortable for operators. Next. And this is where we have problems. There's a heavy calcification of the abdominal aortic and also the bifurcation of the aorta, compromising both common iliac arteries and also some calcification on the common femoral arteries. We were discussing for the vascular access and how to handle this patient. Next. So we show you, this is the right iliac artery with a significant calcification with this spike of calcium in the at the bifurcation near the hypogastric ostium, and also in the common iliac right iliac artery. We have this calcification. Diameters are 4.6 by 8 millimeters on the common, and the external is 4.0 by 7.0. So, and there is also calcification at the level of the common femoral artery, especially near to the bifurcation with the superficial and profunda. Next. So this is the left, almost a similar situation, a little bit tightest here at the bifurcation with the hypogastric, and also calcification on the left common femoral artery. Next. This is all the measurements which were done on the core lab. At the beginning, we thought about going for left femoral access, but then I will let you know why we have decided to change. Next. So this is a potential subclavian access, a lot of calcification and, on the level of the aortic arc in the origin, and also it's not that big, and also tortuous. So it's not an option. Abdominal aortic is not an option for a transcaval approach. There's could be a possibility for transcarotid. We don't have experience with that. So we decided to proceed with our more experienced vascular access, which is the femoral. Next. So in summary, it's an octogenarian with severe symptomatic coronary artery disease and severe aortic stenosis. The heart team discussion suggested an stage procedure. First, the right coronary PCI, which was already shown, and then the TAVI procedure where we are today. Next. So our strategy is the right coronary artery PCI, and then for the TAVI procedure, we are going to go by femoral approach, percutaneous. Our idea was to use PTA with the lithotripsy. We are going to use shockwave just to ablate this notch of calcium. Probably we are going to do a predilatation before, just to prevent any kind of damage of the shockwave balloon. And then we are going to put the introducer set, and we are going to proceed with the regular TAVI procedure with a self-expandable transcatheter heart valve. Next. So this is the balloon we are going to use. This is a peripheral. The range of diameter is between 3.5 until 7. We are discussing here between 6.5 or 7. The sheath compatibility is 6 for the 6 millimeter in diameter and 7 for the 7. We here have an 11. I will show you later on. It's compatible with the O14 wire, and the length is 60 with a working length of 110. So we have a maximum of 300 pulses, and which are going to be delivered here in the common and external iliac arteries. Next. Regarding the valve, the perimeter is in the range of the 29 with the 16% oversizing, which I think is okay for this heavily calcified valve. Next. So we are going to use the 29. Gabriel agreed on that, and he is going to prepare the valve soon. Next. So let's go to live, and I will show you what we have already done. And let me show you the angio, please. Okay. So we did echo for both the common femoral arteries, also angiographic evaluation on AP view, and also lateral views, just to identify which of these common femoral arteries have more calcification on the anterior wall, because calcium there were in both, especially in the lower part of the common femoral artery near the bifurcation. So the decision was to go high, not that high, but echo and angio guided to try to avoid all this notch of calcium to get a better closing after the procedure. So next. So we finally decided to go by the right because it was the calcification. It was not on the anterior wall of the common femoral artery. We did crossover for protection. Next, we did an injection. As you can see there, both we use angio, echo, everything to have the best possible access on the area without calcium. There is a spot there where we don't have calcium. The needle tries to go there. Next. So for this case, I have already mentioned before, in some cases when we have calcium, we still don't have the last version of the ProGlide, so we decided to use the old version of the ProStar, being very careful of that needles go into the sheath, because with calcium, sometimes this needle can go out and you have to resheath everything and try again to be sure that all needles are going into the set. Next. And here where we are, I think this is the last injection. Let me show you what we have here. We have a 7 French in the contralateral access. We have some bleeding because we have a catheter and also a wire, and so it's not the valve is not working perfect when you have two different things in the lumen. And then we have on the right side, after the ProStar, we introduce an 11 French sheath. So we are not going to have any kind of problem for the balloon. So my intention is all this area of calcification of the common at the bifurcation. We are trying not to use too much contrast. We are going to predilate with a 5.0 millimeter balloon, just to be sure that the balloon is not broken during the predilatation. And then we are going to change for the shockwave balloon. So meanwhile, Dr. Murcarcel can describe his finding on the echo performed before the procedure. Juan? ¿Tenés firme? Let's go there. Infla. Okay. 12. Okay. It's okay. It's okay. Inflate. So thank you, Dr. Mucarcel. So you have observed the inflation of the 5 millimeter balloon, and I will tell you two things. First, the balloon was not broken. This is important. And second, the contact with the artery wall was not too much. So I think we are going to use the 7, because if not, we are not going to have too much contact between the shockwave balloon and the calcium. So this balloon is 7 millimeter on diameter. It has 5 measures, 1 centimeter between each one, and the energy is delivered through this metallic dot that you are going to see on fluoro. So it's very important, the previous preparation. It's very important not having any kind of bubbles, because if not, the energy is not properly delivered. So Dr. Carlos Fava and Juan are prepared in the balloon. The other issue is we have here an O14 wire. It's a long wire. Yes. If not, okay, if it is not a bad procedure, how we would treat this stenosis? Well, this is a very difficult question, because we have 4.0 millimeters on diameter, but also we have 8 millimeters. So to be honest, I think the stenosis is moderate. This patient is not suffering from claudication, probably because he is more limited because heart failure and dyspnea. And to be honest, if I don't have to try this, I would have done an echo Doppler evaluation, trying to see which is the ankle brachial index. If it is below 7, probably I would have treated. If I have the possibility to use shockwave, for sure I would use it. If not, I would predilate and will implant self-expandable stent. So here, please don't take out the fluoro sustraction. Saca la sustracción. So I will perform angio so you can see all the dots where the energy is delivered. Here, you can observe we have, no, saca la sustracción. Let me try again. Okay. Here you might see 1, 2, 3, 4, 5 dots which are inside the distal and proximal marker of the balloon. These are the working area of the balloon. So my idea is to pull the sheath a little bit to apply energy here where we have calcification here. Let me show you with this, where we have the iliac bifurcation exactly there. So we will apply the energy from this dot, and this, and this, and this. So Dr. Fava is going to inflate the balloon at 4, but first we have to connect it here. Probably you can show you. We have prepared. You have to make here and here. And now the catheter is connected. There is a sound, which lets us know that it's ready. We have 100 pulses to be delivered. Dr. Carlos is going to inflate 4. There, no more. And I will deliver the energy. You will see some interference on the ACG, and also you can hear some noise here on the sheath. So record it. So every delivering, it's gonna deliver 30 pulses. So we have 10 sessions to deliver the complete energy that is possible to deliver with each catheter. So 6 atmospheres and deflate. Let's deflate. So here is not necessary to deflate, but just in case we have a problem, I will deliver it here 4. So to be sure that I am going to deliver it light dot strip C all the way long of the iliac artery. So it's 4. Let's go again. So Francisco Pancho told me that the middle portion of the balloon is where more energy is delivered. So you need a little bit patient, which is not our main characteristic here. Okay. But anyway, we have to wait. So the other issue is here is okay. 6, don't deflate. Let's go to 4 again, and we can restart the process without deflation. When the console makes a sound, letting you know that everything is ready to go. Why we can do this? Because this is a peripheral circulation. It's something that we are not going to do on the coronary because we are going to produce ischemia. Here to have a longer inflection is not that important. So now we have delivered 60 and now we are close to the 90s. We are going to deliver here more energy. So the discussion was also 6. Okay, deflate. Is if we have to deliver all the energy in the same place, or if the inflation of the balloon is okay and you decided not to go or to proceed with all the pulses that you have ready to go. Let's go. So Pancho suggests me to go with the full delivery, all the doses. We still have some resistance there, close to the bifurcation, so which is the area of more calcified, near the ostium of the common iliac artery. So we have some noise here. ACC interference. It's important to have this in consideration, especially for patients having some electrical device. But here, as you can see, probably you can show the monitor of the hemodynamics where the interference is produced for the next six. Okay. 4. I'm trying to move in just to move the area where I deliver the energy. Deflate, Carlos, so I can move a little bit. Let's go again, inflate, 4. Okay, let's go again. We still have 180 pulses to delivery. We will save some ones to deliver near the bifurcation with the hypogastric. Meanwhile, remember that Dr. Rodriguez is answering question or bringing question to us. So you can make all the questions you want about this procedure or about what we are going to do afterwards. Okay, 6. Once again, deflate. I'm going a little bit lower. Okay, here, let's go again, 4. Here is the external, which is 7 millimeter, but I don't want to go too high pressure here. So we'll keep it on 4, not to 6. So it's a little bit boring procedure. You have to be patient. Ideally, we might not have to implant a stent, but we have a backup for a self-expandable stent in case we have a significant dissection or suboptimal outcome of the PTA. Or additionally, it was to mention that you can do it even having this parallel wire, not only here on the peripheral area, but also on the coronaries. So it does not interfere with the energy delivery. So we still have 100 pulses. Probably we'll do a couple of more and then we are done. We are not doing too much angio, just to prevent renal failure in this patient. Okay, 6, 7. Okay, deflate to 4. Let's go again. This is the key area. You see 4. The bifurcation, 4. So after this, ablation or plaque preparation, I would say, we are going to exchange the wire. We will introduce a catheter through this O14 wire. We will put an extra stiff Amplatz wire to put the introducer set. If we have some problem, we can post-dilate with a 7 or 8 millimeter balloon. 6. Deflate. Okay. Let me see one answer. How is everything doing here? I think it's okay. Let's go with the last one. So exactly there, I will put the last delivery area exactly on the ostium of the common iliac artery. Let's go to 4. We still have resistance there. I'm on delivery again. I have to hold it, and you can see the light here, letting you know that the delivery is going on. The last case we did for a pre-TAVI procedure, it was not necessary to implant the stent in a more calcified because it was concentric. which could be the indication: concentric calcification, very long calcification on the iliac artery, or also this spike notch of calcium, where it's not too easy to predilate. Yes, deflate, and that's it. Because you cannot go too high pressure. Yeah. Okay. Give me, excuse me, don't touch this. We have here, we have to protect here just in case. Okay. Not to contaminate anything. We are going to close the delivery catheter just in case. We still have 30 pulses. Retrieve it. Now you can put the subtraction again. We will do a very short ansio. And then we have to speed up with the TAVI procedure. I think it's okay. Okay, it's much better. Let me go there with the Lima or right or whatever, the Amplatz wire, the introducer. Gabriel, do you have the valve ready? Okay. If the audience has any comment about this part of the procedure, is very welcome. Mostrame un poquito arriba. Yes. Vamos, dame la ampla, dale.
What is the benefit risk ratio of TAVI with self-expanded valve compared with balloon expanded valve?
Well, you know, we don't have so many comparative studies. No, abajo. Saca, Carlito. Ocho. Venía a tener. There is not a direct comparison with only very few trials. I think there are some indications where you might choose choosing one or the other. I have already mentioned here that it's not that easy to select the valve because health insurance, in most of the cases, select the device that you have to use it. Anyway, if for some specific reason, for example, let me know, heavily angulated aorta is more than 60, is out of the instruction for use of the core valve, the Evolut, and also for other self-expandable valves. So this is the situation where probably going with the balloon expandable would be a best option. To be discussed, angulated aorta with bicuspid valves is also a situation where probably balloon expandable is the best option. And then in all the others, to be honest, I don't know. Yeah, of pacemaker. Well, I have mentioned on the previous slide that here we have a probability of pacing, of permanent pacemaker implantation of 2% in cases without previous conduction disturbances, and about 20 something for patients with previous conduction disturbances, which makes an average of about 12.5 or something like this. The patient we did last week was totally unexpected because we have a complete AV block during pre-dilatation with a very small balloon. And this patient needed a pacemaker, which was implanted 2 days after the, 1 day after the procedure. Let me try to cross like this if I can. If you know, we prepare the Amplatz catheter. It's a very calcified valve. I don't know if I'm gonna be lucky. Probably you can now move the monitor a little bit más cerca a mí. Okay, perfect. No more. So bring me the Amplatz because we are running out of time today. No, then we can't. But probably we need a little bit more time and we only have 30 minutes to finish. Okay, let's go. pull the pigtail out. Okay, give me the amplats. Let's go to the conventional way. Straight wire, vía recta. No sueltes porque si no se me quinquea. Okay, dame un poquito de zoom. Saca. We have already prepared the confida with this very small distal tip angulation. Okay, let's go on the right view. Okay, here is when you advance the amplats, you have to pull the wire to prevent any ventricle damage. Give me the amplats wire. I will introduce a loop distal to protect left ventricle wall. And then I will introduce the pigtail. Hold me the catheter, Carlos, the sheath. So I know that many people comment that we don't talk too much here in our lab. This is a characteristic of us. Many visitors always mention that we don't talk too much. This is our characteristic, but here I have to talk because I am live. So now I'm gonna introduce the pigtail. We will measure the gradient. And then over the pigtail, I will introduce the confida wire. Then predilatation with a 20 millimeter balloon. Hold it hard. Tenelo fuerte. Okay. Here it's important to be sure you are not entramped or touching or attached to any mitral cords. Flash. Okay. Then let's go with this pigtail for marker. And here, let's go to the working position. Posición de trabajo, 16, 18, 16, 18 caudal. Okay, this is the working projection for cusp, right and left cusp overlap view. Vamos de frente. Bring the bulb. So we are going to check the loading of the bulb. We are going to pace through the wire. So I think it's perfect there. Okay, thank you, Gabriel. Get back to the position. Give me a minute. Important here to deploy the valve and to see what was going on with the iliac, to see if we retrieve Carlitos, leaving the wire on the distal apex. And now let's go with the balloon for predilatation, the 20 millimeter balloon. Oh, I forgot to measure the gradient, but it was high. Yes. Well, sorry about that. It was close to 80. In correlation with, here I have it, exactly 80. Intraventricular was 189 and in the aorta 109. So exactly 80. In concordance with Dr. Mukarsel's evaluations before the procedure. So we are here. We are not touching too much the LVOT. So vamos a 180, 180. Let's see, we don't have a good capture. Yes, now, yes, let's go. Let's go. Okay, it's okay. Deflate. More, see, out. Holding the groin. We'll pull the balloon. CG is almost the same. Not like last week. Hold it there.
Yes.
Now. And now, let's go with the valve. With the port on the 3 hour to get the best possible cusp alignment. I am not watching what's going on with the iliac, but I could cross very easily. So lithotripsy works. Now let's go with the valve. Carmen, estamos yendo. Okay, just to let Dr. Gomez know that we are ready.
Sí.
Yes. Okay, give me a test. Puff, small. Let's go. Prepárate para 120. Very slowly, slowly. Now is the time to be patient. Okay. Okay. The orientation is not the best regarding the aortic central line. 120, ¿verdad? Okay, let's go. Let's go. Let's go. Let's go. Okay, paralo. Stop. No, déjalo ahí, déjalo ahí. Okay. Ancho. It's not, we have a lot of parallax there. Let's go on the left. I just focus on the non-coronary cusp. There I have 3-4 millimeters. Let's see on the left view. Move the table a little bit. Let's go a little bit cranial. Enough, enough. No, 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 no. It's too much. Menos. Poquito menos. There, there, there. So here, this, I think the position is okay. 2-3 millimeters on the non-coronary cusp. We have a good contact with the left. The right is a little bit upper, probably at 8 or something like this. I think we can deliver it here. We can release some pressure on the wire. We can keep it, everything almost free. And let's go pacing. 120. Please, let's go, Carlos. Slowly, very slowly. Test. Okay. Very slowly. Keep your breath. Okay. Try to centralize a little bit more there. Okay. Let's go. Okay. Now everything is released. Okay, let me pull the pigtail out. You see the position of the valve is okay there. It's at probably 3 on the non-coronary cusp. A little bit under expansion in the middle part of the valve. I am pushing the wire, not pulling the catheter. So the catheter is gonna get back just by pushing the wire. Now the catheter is out. We pull this catheter when we have calcification or significant or concentric calcification on the sinotubular junction. Now is the time for retrieving the delivery system. We still have some minutes. Here is when we use our shape of the wire, the second loop, or second bend, sorry, to centralize the nose cone and to have a safe retrieval. We are going to close. Probably Dr. Mucarcel can check it, the echo. What pone AP. And then we are going to decide whether we have to post dilate or no. Please check it over. Dr. Mucarcel's nickname is Turco, you might know. So I feel the calcium when entering, but not resistance. The wire is still in place. Diastolic pressure seems okay. Probably the configuration of the wave is not the best. Probably you can show the echo now. Okay. Once again, it's transthoracic echo. What about paravalvular leaks? Here the configuration is concentric, not elliptical. There, mild. Yeah, two. Okay, let me check by angio and then you can continue. Poneme en derecha. Sí. Let me check here and then we can introduce the pigtail. Oh, sorry. It was my fault. Sorry. Oh, it was not properly attached. Flash, some push. Okay. It's a very mild paravalvular leak. So I think it's not necessary to use any kind of post dilatation. Do you agree, Gabriel? So, yes. Could you show the angio? Change angio by perfect. So this is the last injection. We have very mild paravalvular, which was shown by Dr. Mucarcel, 2 dots there. And when you can get back to the echo, you can see this dot at 2 o'clock. This is the mild paravalvular leak. When changed by the echo again. There. Sorry. Could you show this picture you had there? You have. This is the. Could you show with the mouse what is the paravalvular leak? Yeah. Yeah. Great. For this description, I will invite you with a very nice croissant after the procedure. You know that in Argentina we have very good things. Croissant are the best. Let me check the gradient. No gradient at all.
No gradient.
Could you show hemodynamic again? Perfect. When we have this supraventricular extrasystoles, the diastolic is a little bit low, but here is okay. So I think we are done. I will pull the pigtail and then I will focus again on the iliac artery. So the TAVI procedure is done. No conduction disturbances so far. Give me the Amplatz wire again. See. Yeah, please. Yes, if Confida is the default wire, I would say that for most of the cases we use Confida. We also use Safari. La panza, Claudio. We use Landerquist, as Dr. Gemal told us. Yeah. In a special situation, heavily angulated, very tortuous iliac arteries, and for the 34. When we are using the 34 Evolut, we use the Landerquist to have a better stability because it's a huge valve to get contact from the non-coronary cuffs to the left coronary cuff. It takes longer time. So if it's important to have a good pacing and a good wire to keep the stability. So let me do a retrograde angio. Let me give some contrast here. Okay, let me dilute it. And let's go with the subtraction. We'll pull the catheter here. We'll hit your hand. No. Careful. ¿Puede no respirar, Carmen? So stop breathing. Breathing. Okay, perfect. Oh, my injection was too weak. I have more contrast. Sorry. Inyectame. Que respire, Carmen. Sí. Okay. It's a long sheath. I need more contrast. Okay. De nuevo. Let's try again. Okay. Perfect. I think we don't need a stand there. No. We have this notch, which was already mentioned. What we can do here is to measure the gradient. Give me the right, no, not the Lima, the right catheter or the templates, okay. Let's measure the gradient and then we can decide whether we should use a stent or not. In my opinion, no. Sorry, Claudio, you can show again afterwards. Después. Yes. I really appreciate all the questions because it helps us to think and to comment something that we can't forget. Let's go. Yeah, Flash. Yes, poddilatation can remove paravalvular leak, but when poddilatation is, is necessary for middle or big paravalvular leaks. So let's check. Could you? Perfect. You are showing the hemodynamics. Here we have 100, I would say 50 or something like this. 40, and then here we don't have gradient. So I think it's not necessary to treat this lesion at all. We can leave it like this with a lithotripsy. Do you agree, Pancho? Okay. Pancho from Shockwave said yes. So we will leave it with nothing behind. So just in case in the future we have to get back and everything. So move here and probably Claudio, you can show on the angio again with zoom the final angio of the aorta. Yeah, this perfect. So there we have two significant calcification there. On the bifurcation of the common and external iliac artery, there is an indentation there, but not gradient at all. And then the notch of calcium on both ostium, but without gradient. So I think we are done. So we are going to close. Carmen is gonna revert hyperinization, and we will introduce a balloon just in case. And 8mm balloon, 8. Because we have a heavily, we have done protamina, yeah. So probably we might have any other question. Yes.
Now,
So this patient is gonna stay in the hospital until tomorrow. If everything is okay, he might go home tomorrow. Let me see, I have a problem here. And for follow-up, we usually ask for echo Doppler evaluation at 1 month for the valve. And probably in this patient, we are also going to ask for echo Doppler evaluation of the iliac arteries and lower extremities with measurements of the brachial ankle index, ankle brachial index, to see if we have significant lesions below. So if not, everything is gonna be okay. So give me some light, but not exactly here, because if not, we are going to saturate the image. Move here. So ponela ahí. Y moverme la camisa. So we still have perfect. It's okay. It's okay. There is okay. 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 Move the table there. Carmen will have finished with the protamine. And here is the main difference with the ProGlide. We have to work. We have to make the notes that are previously done. So this is one and this is the other, which is the white here, white and white. Okay, what we probably can do, Carlos, is to close over the 6 French sheet, just in case we have bleeding, we can use an extra angiosil as an adjunctive device for closing. So it's okay. So please hold it. Okay. I will put the 6 French sheet just to be sure we can enter with the angiosil in case we have bleeding in this complex scenario. So I am tightening. Be careful because I have problem here. Okay. Okay, let me know. Almost one is closed. So we will tie the second one and then we'll retrieve everything and we are done. Let me see, Carolina. You are cross. Release. Okay. Hopefully you are watching there. I have to do this, not 1, 2, 3. Now, Carlos is gonna hold the thread. I have here inside the circle, and now I am pulling. Release. Probably it's not going down, probably because of the set. So I think it's almost okay. We can pull everything out. We are going to close first the first one, and now the second one is moving very perfect. We have a complete healing here. We can do a test through the balloon to be sure. Okay, we don't have flow back here. Let me do something like this. So we still have 2 or 3 minutes. It's on digital subtraction.
Yes.
Okay. Okay, there's a little bit stenosis there. Probably you can put some zoom. There's a little bit oozing also. Probably we can inflate there for 1 minute or less because of not too much. Saca la mano, Carlos. 1, 2, 3. Pon un poquito de zoom. Okay. Still have 2 minutes. Move un poquito por acá. Let me try to close everything okay. the pushers to be sure that everything is okay. Release Carlos. Deflate. And then if we have a small loosening, we have to compress. Perfect. I think it's excellent due to the calcification. We are going to pull this and to put an ancho seal on the 7 French, and the procedure is done. Give me the ancho seal. I think we can release to everybody to go in live for my colleagues, I think in Canada, and we are going to get back at 5 p.m. We have to change the case because we have an emergency procedure, so we have to change a TAVI case for an EVAR case. So we are going to do this TAVI case during the break, and we are going to do for live this EVAR case in a patient with a very complex iliac aneurysm who suffer a traumatic situation and need to be operated on orthopedic surgery, and this iliac aneurysm should be solved right now. So with this, we are done. You see everything is closed here for them.